Very good. I was really worried about having to do the whole next thing. Um, so I'm very happy to come and talk at this meeting again. I'm sad it has to be online, but with COVID, lots of things have changed. This is always such a nice gathering of everyone from all corners of the world. And again, I'm really honored to be a part of it. Again, this will be my third year. So what I am going to talk about today is sort of setting the stage for transplant and MPNs. I have the honor of being both as sort of an MPN physician as well as a transplant physician. It was sort of a mid-career shift that's really allowed me to continue with some of the transplant, but also, take part in MPNs, which I think are a fascinating disease type and a really exciting area to be involved in right now. Now, let's see if I can get this moving forward. I'm getting that circling blue thing on my screen. Okay, great. Now, are we going? You see my next slide?
Don't see it yet.
I don't yet.
Okay.
And you're not in presentation mode.
Oh, huh.
Do you have a
Let me try one more time to see if I can try to share that again. Because it said it was sharing on my end.
Did you put it in presentation mode?
Uh-huh.
Because it looked like you hadn't from our perspective.
Okay.
I
see here. Got it. Yeah. All right. Okay. All right. Can you see it now?
Not yet.
Not yet.
There it comes.
It's coming.
Yeah.
There it
perfect.
is. Got it.
All right. So, setting the stage. What I want to talk about today is sort of set the stage for bone marrow transplant and address things like what is a bone marrow transplant, when to start thinking about it, timing of transplant, and sort of understanding the disease risk, which is really a critical piece of deciding the timing of transplant. So just to kind of start with, what is bone marrow transplant? Bone marrow transplant involves high or intermediate dose chemotherapy followed by a hematopoietic stem cell infusion. And so the chemotherapy, the role of transplant sort of twofold. Number one, I want to replace the bone marrow that exists because the bone marrow that's creating myelofibrosis is not a good one. There's a lot of mutations in it. There's a lot of problems in it. And it eventually causes progressive disease, which, as Dr. Verstafek covered quite nicely in his talk, ultimately progresses towards, unfortunately, death. So by doing a transplant, I'm not going to prevent death, but I'm at least hoping that I can extend people's lives a little bit longer and hopefully get rid of their disease. So with the new blood system, that helps. The second piece of it is I want these new cells, this new immune system, to be able to fight off any less cells that are left behind. One of the hallmarks of the myeloproliferative neoplasms is these cells are incredibly strong. They're sort of almost super cells, in that they are very resistant and want to stick around. So hopefully by getting a new immune system in there, we can actually get a graft, which is that new immune system versus myelofibrosis, which helps keep it from coming back. Now, there's two types of transplants, because this always happens. People come up to me and said, oh, well, my neighbor down the street had a transplant where he used his own cells. And that's considered an autologous stem cell transplant. This is used in treat diseases like multiple myeloma, non-Hodgkin's lymphoma, Hodgkin's disease. This is not a treatment I would use in somebody with myelofibrosis, primarily because the stem cells are damaged. So if I give you back your own stem cells, I'm basically giving back the disease. An allogeneic stem cell transplant is the one that we use for myelofibrosis, and this uses donor cells. So cells from somebody, they can be related or unrelated. There's a bunch of different types. So there's a lot of different names that we use for bone marrow transplant. And even as a transplanter, I in the same conversation, we'll use multiple different ways of expressing it. Peripheral blood stem cell transplant, hematopoietic stem cell transplant, bone marrow transplant. These all represent the same thing. What we're trying to do is get hematopoietic stem cells. And when I say that, these are the stem cells that live in the bone marrow and create the whole blood system. So I need to get them out of the marrow, and then I need to give them to somebody else. So they can be collected through two ways. The first way is in the OR. So the donor is actually undergoes general anesthesia. And I'm assuming probably most of the people in the audience have had a bone marrow biopsy. We basically do about 50 of those on each side and pull out the liquid part of the marrow in order to come up with a stem cell product. The other way, and the more common way that's used now, is peripheral blood stem cell collection. And what we do for that is we give Niblack, which is a growth factor that is often used to help people recover their white blood cells from chemotherapy. So one of its functions is it increases the white blood cells in the peripheral blood, but more importantly, for this purpose, is it actually cleaves off the stem cells from the bone marrow so that they're allowed to come in the peripheral blood and we can collect them. And that collection is done by a leukapheresis, which is, you'll see a person sitting back there with an IV in each arm. The blood is taken out. It's spun around where the white blood cells are separated to one component, the red blood cells in another, and then the rest of the blood is put back in the body, and the white blood cells we hold aside that we use for the transplant. And the transplant works by we collect the donor, we process it. Sometimes these cells are actually frozen, and now we used to try to give them fresh all the time, but now in the era of COVID, we freeze them to make sure that there's no COVID-related delays. Then the patient, who's the person with myelofibrosis, gets this chemotherapy and then gets the stem cells infused. They go in just like a blood infusion would. And all this collection, regardless of if I collect it through the bone marrow or I collect it from the peripheral blood, and gives me a bag like you see on the screen that really looks like a bag of red blood cells, packed red blood cells, but it's a little lighter in color. So what needs to happen to undergo this transplant? So there's a few things that are really challenging about it. Number one, you have to actually live near the transplant center for 3 to 4 months. Now, if you live in a big city, chances are there's a transplant center there and you live there. But if you don't live near a transplant center, or you don't live near the transplant center that you choose to go to, you actually have to physically move yourself as well as a caregiver to live within at 30 to 60 minutes of the transplant center, depending on what their protocol is. Now, approximately 1 month is spent in the hospital, and some programs do outpatient transplant, in which case you go in every day, but frequently we'll have hospital admissions. There needs to be time off of work. So a transplant patient has to take off, if you work from home, I usually don't let people start working till at least 3 months, but if you have to physically go to work and be around other people, sometimes it can be up to a year or more before somebody can return to work. And your caregiver also needs to take time off of work for that first 3 to 4 months, which is the most critical time. As one would expect with getting high doses of chemotherapy, there's really a risk of being really sick. I mean, sicker than it's hard to sort of convey how sick people can get, and you can even die. So you would ask, my gosh, why do I want to do this to myself? And should I pursue a clinical trial? And frankly, I don't blame people for asking that question, because it really is a lot that we expect of people to go through. So what are the common concerns about transplants? So I did a survey on patients with MPNs. We did that, and less than half the patients were referred for transplants, and this is myelofibrosis patients. And of the patients who saw a transplant specialist, less than half of them actually proceeded on. Half of them were going to proceed with the transplant due to concerns, and the concerns were things like quality of life, the financial implications of transplant, having an appropriate caregiver, and then the worry of graft versus host disease. Graft versus host disease is one of the big complications we get of transplant. Just to kind of, as a side note, graft versus host disease is when that new immune system, which I really want to go in there and fight off any last bits of disease, unfortunately fights good tissue like your skin, your liver, your GI tract. So these were all big concerns that people expressed and reasons why they didn't want to proceed with the transplant. And so why is this? I think we need to understand better about what people think about it. In many circumstances, I will often just see the patients who do want to go through a transplant, but there's probably a number of them who don't. And then that's when we talk about clinical studies and stuff like that. So there's other consideration. Physicians are humans and have biases. I think that the process of transplanting myelofibrosis has really improved over time. So even 10 years ago versus now, I think we're much better versed on the timing of it. we're much better at doing these transplants. So if somebody trained 10 or 15 years ago, they're going to think, oh my God, that was just the worst thing that I saw during my fellowship. I don't want somebody to have to go through this. So they're going to have inherent biases. Sometimes transplant physicians even, might be biased in one direction or another. And it's sometimes hard to sort of read through those biases, because even if somebody doesn't physically say, oh, this is what I think about transplant, there's all these nonverbal communications that occur that indicate what people feel about it. And then the other thing is that there's blogs. Everyone likes to tell their story, and everyone experiences transplant differently. So there's a number of people who will go online and explain how their transplant was the worst thing they ever experienced in their whole entire life, and it was horrible, and nobody should ever go through that. There's a lot of other patients who don't have that same experience, but it's much easier to think of the bad things rather than think of the good things. And we're all seeing during this COVID pandemic how much the internet can affect people's belief systems. And so then the question is what about clinical trials? We're hearing about all of these great new agents that are being tested, and Dr. Mascarenas will talk later and really will give a fantastic overview of all these drugs that are being tried in myelofibrosis. It's actually a really exciting time. All that being said, although we are starting to see improvements in how people are doing, there is still no curative option with clinical trials at this point. And so transplant, it does remain the one curative option for this disease. But this is a very individualized decision. It's not something that, I think a lot of times people might be disappointed when they meet me, because this isn't something that I can say, okay, you definitely need a transplant. This is when, this is why, period. Because it's not quite clear. There are other disease types that I have transplanted or transplant that people come in and I say, okay, this is a no-brainer. We absolutely recommend a transplant. This is the timing. And those are a lot easier than the conversations of, well, there's not a completely set time for this. This is something that we don't always know the best idea. We have to kind of explore people's belief systems, their goals, their, what they value, and really have to come to sort of a decision that is made with both the provider as well as the patient to figure out what's the best route to take. So when should somebody see a transplant specialist? I strongly advocate seeing a transplant specialist early in the disease course. Even if you aren't sure whether you'll proceed with transplant or not, even if you say, well, by the time I need a transplant, I'll be too old. A lot of things I hear is, well, this is the last resort. But it's really important to meet a transplanter earlier on in the disease process, and there's a few reasons why. Number one, there's a ton of information to process. And then by seeing somebody early, you can sort of process that information. And the way I look at it is you put it all in a big box. And you open that box sometimes, and the minute that opening that box and that information gets too stressful, you put it back in the closet in your mind for a while, so you don't have to think about it. So that gives you time to really process all that information in the box. It also allows the different resources, to mobilize the different resources needed for transplant, the caregiver resources, lodging, financial resources. These are all, can be a challenge to get for people. Not everyone has a spouse who doesn't work or is retired. I mean, your spouse might be working, your caregivers might be working. You have to mobilize a lot of people because you need somebody with you 24/7. The cost of doing a transplant is not cheap, even if insurance covers it. There's co-pays. There's the fact that your caregiver will be out of work for a while. There's the fact that you might have to pay for additional lodging. And also understanding the process of transplant. And one of the key reasons to actually seeing a transplant doctor before you need a transplant is to figure out the timing piece of it. Because a lot of times the perception is, well, I will use this when nothing else is left to treat. But if you wait until that time point where there's nothing else left to treat, chances are the disease is far enough progressed that unfortunately, even with a transplant, it's not going to be helpful. It's the key piece of this, and I think Dr. Deeg, who you'll hear speaking soon, had said this at one point, and it's a perfect phrase, is that you want to get your transplant before you think you need it. Because if you wait till you think you need it, a lot of times you've waited too long. And so seeing a transplant specialist early will sort of help this process move along in one's head and really help with the timing and the decision-making process. So who should you see? Well, I think there's a lot of factors that go into this deciding on a transplant center and a transplant specialist. I think the first thing is, where do you live? I mean, if you live in a city that has a transplant program, even if they don't necessarily have somebody who really focuses on myelofibrosis transplant, there's a lot of reasons to go closer to home, because, you're living at home, you'll have your support system around you. That being said, I think it is important to at some point at least have a conversation or a second opinion or something with somebody who does really think about a lot of transplant with myelofibrosis, because there's a lot of nuances to it that even exceptional transplant doctors don't necessarily think about. The timing of transplant is a shared decision-making process. There is very few times that somebody comes in and I say, you definitely need a transplant, we need to go now. Usually it's, okay, well, you'll need a transplant. What's that timing look like? How are we going to follow you? What are the indicators that we are getting closer to that time point, and when should we go? And again, it is very important to have a good discussion or opinion, and if at all possible, even a second opinion with somebody who does think about transplant for myelofibrosis. So what do you want to expect when you go to this consultation? Number one, bring a family member or a friend. It's always good to have a second set of ears, because you're going to be scared. There's going to be a lot of things I know that come out of my mouth that terrify people, and would terrify me if I was sitting in the seat of a patient. And the problem is that you have an hour, and I have a lot of data to cover, so I usually keep going, but you might hear something that totally freaks you out and the brain freezes, and then you come back and I'm already 3 sentences ahead of time. And a lot of times people don't tell me that, and I keep going. So it is really important, because then maybe you and whoever's with you will be freaking out at different moments, so you'll be able to put together a better picture of what happened. If you can, record the consultation. Put it on, everyone now has iPhones or some type of smartphone, and you can usually record on those. And if you have any doubts, get another opinion, because this is a huge undertaking, and it's something that can, even under the best circumstances, cannot end well, in which case you really want to know that you made the right decision. So when should you get a transplant? This is something that is really based on risks. Historically, we used to take higher risk patients, but we're learning that it's very important to take people earlier on in the time course, and then we have better outcomes. So knowing the risk is important. How do we define this risk? There's a bunch of different scoring systems, and I know that quite a few of these have been covered in other talks, so I'll just go over them briefly. One is the Dynamic International Prognostic Scoring System, or DIPSS, which takes into account various factors such as white blood cell count, blast percentage, constitutional symptoms, whether you're requiring blood transfusions, platelet count, etc. And just the clarification of risk. The anemia is a hemoglobin of less than 10. The thrombocytopenia means a platelet count of less than 100. White blood cell count is one that's greater than 25. And the blasts, which are the baby white blood cells or immature white blood cells, of greater than 2%. And as Dr. Verstofik mentioned in his talk, again, it's common to have some blasts in myelofibrosis. When they start to creep up in number, you get more concerned, and when they're greater than 20%, that's actually when somebody's considered to have acute leukemia. Another thing that is a risk is abnormal karyotype, and the constitutional symptom, which is chromosomes, and constitutional symptoms include fatigue, weight loss, decreased appetite, night sweats, etc. So there is an online tool, and this is from a little bit ago, so I actually didn't check to see if they've updated it at all, but there's a stem cell transplant spectrum timing tool. And what this is basically looking at is they go through all these different risks, and they say, well, where are you with low risk, intermediate 1, intermediate 2, or high risk? And even in the case of low risk disease, it is important to start the conversation for the reasons I mentioned before. So I always like to draw this diagram when I talk to patients about transplant. So you have this point over where this arrow is the diagnosis of disease. There's DIPSS lower, intermediate 1 risk, intermediate 2 risk, and high risk. Now, granted, there's a lot of fluctuation between these different risks, and you can be DIPSS intermediate 2 risk one day and intermediate 1 risk the next day. So you have to take a little bit of this with a grain of salt. But this is when you want to be thinking about transplant, and I should probably even modify this so you're thinking about transplant in low risk or intermediate 1 risk. Sometimes people are diagnosed in intermediate 2 or high risk, in which case it's a moot point. You just go to the, you talk to the transplanter whenever you are diagnosed. But if you are diagnosed early in the disease process, you really want to be thinking about transplant earlier on. And then when to do a transplant, it's usually around DIPSS intermediate 2 risk, but there's a lot of caveats to this. We're learning that you may actually want to go a little earlier in the time course, especially if there's high risk features. So what contributes to these features? The driver mutation, cytogenetics, and then the molecular mutations are what people have been referring to as next generation sequencing. So the driver mutation, we know that if you have calreticulin, it's good. If you have none of them, it's bad. In between, whether JAK2 and MPL, it varies depending on the study you're looking at. But I think that the key take-home message here, as you've heard in other talks, is that calreticulin is good, and having no driver mutation is generally not associated with a good prognosis. The cytogenetics or karyotype, there's multiple different abnormalities that can be seen in the karyotype. This is something that is generally found in your bone marrow biopsy report. Just so you know, these are not inherited chromosome abnormalities. They are changes that occur in disease cells. So many people worry, well, what does this mean for my kids? Does this mean that they're going to inherit these same chromosome abnormalities or mutations? And although there may be some predisposition that's inherited, there's really no clear data that these mutations that are causative of the disease are passed on from family member to family member. Then there's a next generation sequencing, and we've heard about these different mutations in various talks, looking at some of the more high-risk mutations, such as the ones that I have circled in red here. Again, I consider this the alphabet soup of the conversation, and I say the specific letters and numbers are maybe not that important, but it is important that you know this information so that you can make decisions appropriately based on that. And so when to do transplant, now we're thinking that with the bad risk chromosomes and mutations, you might actually want to get someplace well in the intermediate 1 risk range. If you have good risk mutations, maybe you have a little more time to wait and go in the intermediate, the DIPSS intermediate 2 risk range. And, again, as I said, there may be an earlier time frame that we should be taking people to transplant, especially when they have high risk mutations. This is something that none of us truly know the right answer to. And I think we all make our best assumptions and our best guesses based on what we know. And then that's where it becomes a shared decision-making process, because there's no clear time of this is exactly when you should do a transplant for myelofibrosis. Other things to consider, symptom burden, whether somebody's on Jakafi and how well they're responding to it at the time, whether somebody needs blood transfusions, what actually gives points. So I'll give you a few situations that show sort of some of our limitations of our scoring systems, not to make it more confusing, but to also recognize when you go and talk to a transplant doctor, this is why you need to think about this shared decision making. So if you have a 64-year-old person who has primary myelofibrosis, they're calreticulin positive, on 2 different months, you can actually have very different DIPSS scores. So this is one of the things that when I'm meeting with somebody, I really want to get a sense of what their counts have been doing over time. Now, if you look at these blood counts, they're not very different from one another. So in this type of person, I would be looking at things like the CALR positivity, which conveys a better risk disease. If they were JAK2 positive, maybe I wouldn't, I'd say be thinking we're in a sooner time frame. If they had ASXL1 mutation, which is one of the higher risk mutations, this is the type of person where I'd be thinking, we really should be thinking of whether we want to move forward with transplant now. Example 2, a 58-year-old female with post-essential thrombocythemia myelofibrosis. So post-ET myelofibrosis. Hemoglobin of 7, requires blood transfusions every month. White blood cells are not elevated, no increase in blasts, no symptoms. In this situation, this patient would be intermediate 1 risk, but requiring transfusions every month is something that would really prompt me to say we need to move forward with transplant sooner rather than later, even in the absence of having high white blood cell or high blast percentage. And then finally, 65-year-old gentleman with primary myelofibrosis, JAK2 positive, he's going to the hemoglobin of 9.5, which is almost at the 10, which is where the cutoff is. Normal platelets, normal white blood cells, no increase in blasts. This person would actually meet the criteria, the DIPSS intermediate 2 risk criteria. But there's somebody who I probably wouldn't be pushing to transplant super quickly. I would say this is something that we need to have a conversation about because of the fact that they primarily are getting points on hemoglobin. Again, this is where next generation sequencing and some of these other risk factors really help in the conversation, because if they, for example, had an ASXL1 mutation, then I would say, you know what, we probably want to go. But then if they didn't have an ASXL1 mutation, you know, if they were 64 years old, they'd actually be considered intermediate 1. And we truly know that in many circumstances, there's not a huge difference between the two. So these scoring systems have to be taken with a grain of salt. It's not a cut and dry. Your DIPSS intermediate 2, you need to go to transplant now. You know, your DIPSS intermediate 1, you're too early for transplant. It's not that cut and dry. There's all these other factors that go into it. So other questions. Well, I feel so good on Jakafi. Why should I go forward with transplant? We do know it's probably better to move forward with a transplant while you are responding to a JAK inhibitor versus waiting until you've progressed through one. Once you've progressed through a JAK inhibitor, we know that the prognosis is somewhat worse. The disease has probably changed on a mutational basis and will be more aggressive. So it's probably good. Now, where that sweet spot is between having your response to Jakafi and moving forward with transplant is something that is again, falls into that gray zone. There are newer agents in clinical trials that may reduce my mutation burden and fibrosis. Will these cure the disease? I don't think we're quite there yet. Hopefully at some point you won't need me to be a transplanter and just need me to be a myeloproliferative disease doctor. And then should I do a clinical trial first, then transplant? Well, I think at this point, I generally say if we've identified somebody who's appropriate for a transplant, and I'm not using a clinical trial that's for early on in the disease course, of which there's more of these now, but I'm not using a clinical trial for that setting, then I generally say we probably want to just go forward with transplant because, you know, again, with all these clinical trials, we're trying to see whether they will work or not. And if a transplant is something that's on somebody's agenda that they want to do, I will usually try to encourage going to transplant. Now, that being said, sometimes that clinical trial buys 6 months to a year that for somebody to sort of go through the processing that they need to, and it's a step in between. So it's not the wrong thing to do. You know, I'm hopeful that with some of these newer agents, we'll actually be able to identify the right patient to get on these agents prior to transplant, because maybe that will set their marrow up to be in a better situation to receive a transplant. So there's a lot of things that we don't know yet. But I think the take-home message is that transplant remains the only curative option. If you are going to go forward with a transplant, it's generally best to sort of make the decision of when you want to go through and then go through with the transplant, but not try a lot of things to set the transplant back, because that puts the risk of having other complications or illnesses in between that may affect the outcome of the transplant itself. So in summary, bone marrow transplant is a curative option for myelofibrosis. The best time to undergo transplant is still under investigation. None of us know. That's why it's really important to have a good discussion with the transplant physician about this question, because we don't have a perfect time that we should say this is exactly when you should go to transplant. And it's something that's an individualized decision for a patient that, you know, I've had patients who say, well, you know, I really don't want to go to transplant right now. I want to wait till my kid graduates from high school. Or I need to wait another 6 months because then I'll have my insurance put in a certain place. Or I'd like to wait till summer because my kids will be out of school. It will be easier to move. So there's a lot of things that can really impact the timing of this. But the most important thing is understanding your risk, because understanding the risk of the disease will really help in saying when should you think about transplant. And it just informs us. It gives us more information so that we're not kind of shooting in the dark. And the beauty of all the research that's happened over the last 10, 15 years is now we have a lot more information that will really help us better characterize disease risk, be able to predict what's going to happen. None of it's a crystal ball yet, but at least it's better than we had before. So knowing your risk is probably one of the key pieces to this. And just in conclusion, I love to put these pictures up. These are patients that I have transplanted who are survivors. And they're going on with their normal, regular life without their disease. And so there's definitely a light and hope at the end of the tunnel. So even though when I have to talk about transplant, there's a lot of scary information, there is a light at the end of the tunnel, or else I probably couldn't continue to do this. So transplant is something that for the appropriate patient is a very, very good treatment modality. And that is the end of my talk. And I think there'll be a question period later. So if anyone has questions, I'm more than happy to take them.